Welcome to Pulse and Pressors, where critical care gets crystal clear. Carotid revascularization exists for one reason: stroke prevention. Both carotid endarterectomy, CEA, and carotid artery stenting, CAS, aim to stabilize plaque, eliminate embolic potential, and restore reliable perfusion to vulnerable cerebral territories. Carotid stenosis is driven by atherosclerotic remodeling. A plaque with a lipid-rich core and thin fibrous cap is unstable and prone to rupture, releasing microemboli that lodge distally in cortical and subcortical microvasculature. Flow-limiting stenosis compounds injury by lowering perfusion pressure. CEA removes plaque directly. The surgeon opens the carotid artery, cleaves the plaque from the arterial wall, and restores a clean lumen. Patch angioplasty is frequently used to prevent narrowing. CEA is durable, reproducible, and often the gold standard. CAS uses an endovascular approach. After establishing access, typically femoral, operators deploy an embolic protection device and expand a stent across the plaque. CAS minimizes surgical trauma, but carries a higher risk of periprocedural embolization, particularly in older patients. Indications for intervention depend on symptom status and stenosis severity. Symptomatic patients with greater than or equal to 50 to 70% stenosis benefit strongly from revascularization. Asymptomatic disease requires greater than or equal to 70 to 80% stenosis or high-risk plaque features, such as ulceration or embolic showers. Deciding between CEA and CAS requires anatomic and clinical analysis. CEA is preferred in older patients, those with favorable anatomy or low surgical risk. CAS is optimal when the neck is surgically hostile. Prior CEA, radiation fibrosis, tracheostomy, or high cervical lesions. Hemodynamic management drives outcomes. Cerebral perfusion depends heavily on MAP. Hypotension risks watershed infarction. Hypertension risks hyperperfusion syndrome. Vascular teams rely on precise BP targets pre- and post-procedure. Intraoperatively, CEA introduces a period of carotid cross-clamping, often mitigated by shunt placement. Neurophysiologic monitoring, EEG, or cerebral oximetry, detects perfusion dips. CAS risks bradycardia or hypotension during balloon inflation due to baroreceptor activation. Both require careful heparinization to minimize thrombosis. Immediate post-op care is critical. BP checks every 5 minutes detect early instability. Hourly neuroexams identify embolic events, hypoperfusion or hyperperfusion. Airway vigilance is mandatory because a rapidly expanding neck hematoma can cause airway obstruction. After CEA, BP goals are tight. Map 80 to 100 millimeters of mercury to support cerebral flow without overshooting into hyperperfusion syndrome. Pain control is essential because pain-induced hypertension can trigger complications. After CAS, baroreceptor resetting may induce hypotension or bradycardia. Maintaining MAP greater than or equal to 75 to 85 preserves cerebral perfusion. Vasopressors may be required early, particularly phenylephrine or norepinephrine, if contrast dye was used during the procedure. As is the case with CAS, expect IV fluid administration to flush out the kidneys. Major CEA complications include neck hematoma, cranial nerve injuries, especially 12, 10, and 7, hyperperfusion syndrome, and, rarely, patch disruption. Immediate airway evaluation is mandatory for swelling, stridor, or dyspnea. CAS complications include embolic stroke, restenosis, and hypotension, or bradycardia from carotid sinus manipulation. Femoral access site hematoma or retroperitoneal bleeding must be monitored closely. The patient can expect to remain flat for several hours post-procedure. Hyperperfusion syndrome is the feared complication of both CEA and CAS. These patients have lived with chronic low perfusion. Restoring normal pressures suddenly overwhelms fragile microvasculature. Headache, seizures, and focal deficits can appear within hours to days. Post-procedure medical therapy includes lifelong aspirin for all patients. CAS requires dual antiplatelet therapy for at least 1 to 6 months. Statins stabilize residual plaque and reduce recurrence risk. Blood pressure management remains lifelong. Escalation is required for new deficits, neck swelling, severe hypertension, refractory hypotension, or seizures. These signs may indicate hyperperfusion injury, intracranial hemorrhage, neck hematoma, or embolic events. Rapid imaging and vascular consultation are mandatory. Carotid revascularization is a balance of anatomy, plaque biology, and precise hemodynamic control. When performed and monitored correctly, CEA and CAS dramatically reduce stroke risk. Mastery lies in understanding plaque behavior, matching the procedure to the patient, and managing the perioperative hemodynamics with discipline. This is Pulse and Pressers, reflecting on the marvels of the human body. Subscribe to stay sharp.